live and talking about breastfeeding difficulty. So, hi everybody, my name is Christian Fludder. Thank you very much for joining me today. We're going to be doing a couple of things a little bit differently. First, compared to last time, we're minus a couple of children who are busy saying mop, and this time we also have fancy computer stuff going on. So at the moment I'm also streaming on YouTube, and I'm actually going to be doing a lot more on the YouTube side of things. I can switch between utilizing screen sharing and all that kind of stuff a lot more easily. So if you'd like, you're welcome to jump in on that one and have a look. Let me just quickly create a sharing link, because that would probably be very helpful for everyone. If I click these buttons, oh look at that, it says the live now thing, get shareable link. And let's just do a few button pushing. I probably should have had this all organized before jumping on this and clicking buttons and saying, yay, we're live. Okay, so now that's gone, let's get into the fun part. So the fun stuff we're going to be talking about today is really about breastfeeding difficulty. And this is actually stemming from a paper I recently had published, and it was talking about a child who came in to see me with breastfeeding difficulty. Sorry, I just managed to bump that thing over, which is not ideal. There we go. I had a child who came in with breastfeeding difficulty. Not just that, but also failure to thrive. Now, this is a bit of an interesting case because, you know, when you've got a case who's failing to thrive, they're 4 weeks of age, they're not putting on weight very well, you've got to play really quite carefully, because you obviously, little changes can have a dramatic effect, especially at that age. If they start dropping down a little bit further with their weight, it can start having a serious impact on their health and well-being. So we had to do a lot of things with this case. Firstly, we had to co-manage. Okay. Now, as a chiropractor, and I think a lot of other health professionals will feel similar in regards to this one. In fact, they did that one with the WBTI report a couple of years ago. Naomi Hull and somebody else, I can't remember. Ooh, sorry, my apologies. They talked about all the health professionals who have met minimal requirements for breastfeeding education and training. And of all the health professionals, midwives and health nurses were really it. In fact, I'm pretty sure it was just, no, sorry, my apologies, lactation consultants, IBCLCs, and midwives were the only two that actually met the requirements of minimal breastfeeding education. So chiropractors, osteos, physios, pediatricians, general practitioners, they did not hit adequate points in regards to their education for breastfeeding assistance. And so this is where collaborative care comes in really important. I know my skill set, and I know that my particular skill set is much more targeted towards helping kids in a musculoskeletal fashion. Okay, so when it comes to breastfeeding assessment, well, firstly, I'm a little bit underqualified in regards to the breast component, but I've been through the experience with a couple of my own kids. And so when I'm looking at a child who's had breastfeeding difficulties, I want to ensure that they're getting the best possible assistance in the whole process. So this required collaborative care with their child health nurse, with their general practitioner, and most importantly, with their IBCLC. Now, I say IBCLC, and I'm going to use it interchangeably with lactation consultant, LCs. IBCLCs actually have a lot more requirement. They've got a lot more education and training involved than what is required just to get the title of an LC, but we don't need to go into that one today. So essentially, this case had been seen by all these other health professionals as well, to ensure that we're not looking at a case of pathology. We're not looking at a case of structural defect, because this is one of the things that we're seeing a lot of at the moment is concerns with tongue tie. Okay, is it a tongue tie? Is tongue tie causing my child's breastfeeding difficulty? And then the question is it a tongue tie? Is it a lip tie? Is it a buccal tie? Can these ones actually influence the function of breastfeeding? And so we have to ask the question then, is it a functional or a structural, or is it something that's actually the result of something else? You see, a lot of the tissues in our mouth and jaw, they are driven by other factors as well. So we can have the neural control over these areas. So we're looking at maybe lips or our tongue. There could be difficulties in movement or control or regulation of those areas. And as such, they don't get the same sort of movement and accurate representation of their mouths. So this was one of the beautiful things about having a collaborative case in this child, a collaborative care in this child, is that we've got a GP who has done all the pathology side of things. We've now got an IBCLC who's ruled out the tongue ties, ruled out lip ties, ruled out any other indicators of oral tethering that could be possibly going on. So that leaves what we found to be the potential cause for this breastfeeding difficulty. Now, in this child, we found a couple of things. First, let me bring up the paper and you can have a bit of a read of it at the same time as well. So let me click a button and then hopefully, and look at that, it's done the thing. That's fantastic. So what you should be seeing here, unless you're on Instagram, which I'm sorry, because you're not going to really see the beauty of what you can see on YouTube. So what we're looking at here is the original paper. So the first things first, I'm just going to move this one up and out of the way a little bit. There we go. What we're looking at here is chiropractic management. Okay, now I found this title to be important because it suggests that it's more than just manual therapy. We're actually involved in managing this case. There was more to it than just us having a look at structural or musculoskeletal restrictions and correcting them. Now, the second thing that we actually do need to pay close attention to in this paper is this. It is a case study. Okay. What does that mean? It means that it is only one case. You cannot extrapolate this to the greater population because what worked for this one girl may not work for everyone else. Okay, so we do need to be very mindful that this is just a case study. What it does open up, however, is the possibility of further discussion in regards to how chiropractic can manage cases like this or where chiropractic management may fall in when we're looking at it. Here we go. Yay! That's always nice to see. A big shout out to Janelle. Thank you very much for helping so much with this paper. It would have been a lot more of a tricky task without your involvement there. So that was great. Abstracts are always fun, but they don't really tell the whole picture. So let's get into the main part of this one here. So when we look at this paper, one of the reasons that we chose this as a case study is we're seeing a lot of drop-off in the rate of exclusive breastfeeding. See, what we're looking at is we want to have exclusive breastfeeding. WHO and the Australian Breastfeeding Association tried to promote 6 months of exclusive breastfeeding, and where we're pretty good. So the starting percent, so 90% of breastfeeding mothers will initiate breastfeeding. But the concern is this drops off pretty quickly. By 4 months, this is only, I got to remember the statistics, about 40%. And then by 6 months, this is right the way down to around 15%. Okay? 15% of parents are exclusively breastfeeding by the time we've reached 6 months of age. Okay? Now, if we can help to calm down one potential cause of that, that may help to increase the number of parents who continue with exclusive breastfeeding to 6 months and beyond. Now, there are many reasons behind this one. Okay, so breastfeeding difficulty is just one reason that parents may choose to stop with breastfeeding. And look, if you have had to stop breastfeeding, there are many reasons and it's up to you. Okay, that's why we have formula these days, and thankfully formula is pretty good. So if you do have difficulties or problems, or if you choose to discontinue breastfeeding, that's I'm not here to judge. We can have painful breastfeeding. We can have structural problems. We can have, there's a gamut of reasons. So let's not get into that one now. So essentially what we're looking at here is the important factor is that it's a high drop-off. Okay, and one of the most commonly cited reasons. So this is back in 2013, I believe it was, a chap by the name of Odom, an American study. They found this breastfeeding difficulty with attaching and sucking to be one of the most commonly cited reasons as to why a child may discontinue or a parent may discontinue with exclusive breastfeeding. And that is something that we were looking at in this paper as well. See, how do you attach? How do you latch? How do you suck and swallow? Well, it involves a lot of the stuff in and around here. Now, if we have a look at this paper here, so back to this paper, I actually talk about this one. Breastfeeding itself is a straightforward yet complex process, and it actually involves 60 sets of muscles. Okay, 60 sets of muscles to help coordinate this motion. More than that is it involves 6 sets of what are called cranial nerves. Now, cranial nerves are a pretty funky little thing. They are a region of the upper part of our spinal cord, right up to where it almost transforms into being the brain, is a region known as the cranial nerve region. So we've got a whole bunch of cranial nerves. So some of them are involved in moving our eyes all around, some of them are involved in hearing, and a lot of them are involved with this kind of stuff. So I use facial muscles, for instance. I need to be able to purse my lips, open my mouth up. I've got muscles of mastication, the jaw chewing muscles. I've got muscles that move my tongue around. And each of these ones, different sets of these muscles are controlled by different cranial nerves. Now, one of the big cranial nerves that we like looking at, is called the vagus nerve, cranial nerve 10. Now, it's getting a lot of attention recently because it's involved in a lot of stuff. We're finding that it's involved in like your heart rate, it's involved in tone, it's involved in gut function. Okay, have you ever had that feeling of like butterflies in your tummy and you kind of feel like that, ooh, that's actually your vagus nerve sensing something. And in fact, you know when you get that gut feeling, you know when you say, oh, I've got a gut feeling about this place, that's your subconscious picking up on a lot of things and your vagus nerve having a bit of an upregulation and result and responding to the environment that you're around and in. Now, the thing with vagus nerve, it actually ties in with a lot of other little things as well. Now, I talked about these ones as well, so let's just go back into this paper here again. The vagus nerve, it's tied in with, oops, that's not a highlighter. Awkward. These are the joys of live streaming, I suppose, is you don't know which one you're using. We're looking at problems with breathing, okay, sucking, swallowing, as well as lower esophageal tone. Now, what on earth is the lower esophageal tone got to do with things? Well, it's actually one particular part. So back in 2000, Hornby and Abrahams did a study looking at one particular muscle called the lower esophageal sphincter. Okay, so if you could imagine when we've got I'm going to draw a picture on this somewhere. Where's somewhere good? Oh, I don't have a piece of, you know what I'm going to do? I'm going to click on here and make a thing pop up. Let's see what it looks like. Ooh, fancy. Except taking forever to load today. It wouldn't surprise me if it does an update. Oh, there we go. Oh no, look at that. So this is what happens when you have children. They design things and make things look really quite funky. So let's just clear canvas. Do that. Okay, so inside our body, we've got, that's not a drawing thing, let's draw a drawing thing. We've got our head, and we've got a mouth here, and we've got eyes. Okay, this is probably the most non-representative person I've ever drawn, so that's wonderful. We've got a tongue inside our mouth, we've got the roof of our mouth here, and then we've got the esophagus coming down through here before it turns into the tummy, so it's full of all that liquid and digestive stuff. Now, when we swallow, firstly, food goes in through our mouth here. We need to close our lips so we can create And here it's true. Well, we don't need to, but when you're a baby and you've got liquid, it's easier to swallow liquid with your mouth closed. Otherwise, you end up dribbling it all over the place, which can be interesting. It comes down the back of our throat, right? And it comes down into our stomach. When it's inside the stomach, it should stay inside the stomach. Now, the lower esophageal sphincter is a muscle that sits down the very bottom of our esophagus, and it sort of keeps it nice and tight. So if you're a baby and you have to lay on your back, for instance, you've got this thing that's meant to be holding it all together, and it stops content from coming back up again. Now, if it is not working properly, that's when we start to get some of the indications of vagal dysfunction. Now, again, caveat with this one is some kids, it just may not have developed fully at that stage. Not all kids have these ones fully developed at birth. It takes time, okay? But we do often see certain indicators of vagal nerve dysfunction, okay? Big ones. We're looking at coughing, choking, gagging, dribbling, reflux, regurgitation, and or, I'm just going to get rid of this one, vomiting as well. So if you have a kid who's coming in and they've got a lot of vomiting behavior or reflux behavior, or they're dribbling or leaking milk out to the side, this may be an indication that we've got a bit of a failure of our vagal nerve system. So the vagus nerve itself is having a bit of a hard time working. Now then, this leads to the question of what causes a vagal nerve disruption? How do we get, I've got to click on a thing. There we go. Oh, people, hello. I can't see the bottom of my phone there on Instagram. How about that? Look at that. Hey, people. Okay, so anyway, train of thought. How can we end up with a vagal nerve dysfunction? Okay, so firstly, we're a kid. How does a kid end up with a problem like this? Well, a couple of years ago, I had a paper published about this one. Being born can actually influence the way your neck works. Now, this then ties into if you've got a problem inside your neck, could this interrupt with cranial nerve function? This is something that's becoming a little bit more researched over the last little bit. A lot of researchers are starting to look into what's known as heart rate variability. Okay, it's becoming a bit of an easy to test thing to see how the vagus nerve is going. See, when we're all nice and happy and healthy, we should have a good variety in our heart rate variability. But when we've got a bit of a problem, it starts to plateau out. We don't have as much variability. So they did a few studies on this one. There's quite a few, and actually I think I spoke about them again in this paper here. And it's talking about heart rate variability as a reflection of cervical spine dysfunction. Okay, so let me rephrase this one. In fact, let me show you here. So it's inside this paragraph here. If we have dysfunction to the cervical spine, this was shown in a laboratory study. So this one here was a laboratory study, and these ones, a few of these ones are looking at adult studies. So there's not many done on kids. And it's saying that change to normal spinal function in the neck can create a disruption to cranial nerve activity, because what they were looking at is they looked at kids with spinal dysfunction and they looked at this heart rate variability and they thought, oh, okay, no, not so great. They corrected the spinal dysfunction and this improved the heart rate variability. Okay, so it's a bit of a one to draw at this point in time. There's still more studies that are needed to be done on this one. We might have something in the works about that, which is exciting. But what we're looking at here is if we have a change that improves heart rate variability, that then tells us we may have improved vagal activity. And we would then expect to see improved vagal activity across the board of what the vagus does. Okay, one of them being keeping stomach content down inside the gut. Now, this is the thing as well. The upper part of our neck, it plays more than just simply cranial nerve activity. There are other things too. So even things like being aware as to what you're doing. You know, sometimes kids have a really hard time finding a nipple. I mean, like, how hard can it be? The parent puts that thing like right in front of their face. They just have to and put that in there and all sorted. But no, kids, they do a thing. It's called the head bob reflex. It's actually a primitive reflex. It's like bobbing for apples. And that may be because they're not fully aware as to where they are in space. They might be having a bit of a harder time actually finding whereabouts their mouth is to get an accurate, or not to get accurate, well, to actually latch on appropriately and attach appropriately. Now, this then leads into other things as well. If we have dysfunction in the vagus nerve, the cranial nerve system there, we're going to start seeing problems with coordination with swallowing. If you can't coordinate your swallowing, even as a grown-up, you ever taken that time when you forget that you're actually meant to swallow first, then breathe? And when you do that, and you do a bit of a moment, kids can do that too, okay? This could be a reflection of, again, spinal issues. So very fun times. This was something that I really enjoyed about this paper, is that we were able to talk about these ones as potentials. Look, it's going to take more research to figure out exactly what's going on, and that's really the key of it, is where we're just opening the door a little bit, opening the possibility. And that's what I find to be really fun. Now, I've just realized I've done a whole bunch of clicky things, and oh no, that's fantastic. Nobody's asked any questions. That's good. So I'll just keep on talking then, because that means I can keep on talking. That's a good point. If you have a question, feel free to ask. Let me just lift this one up and say, can't see on Instagram. Oh, okay. Oh, no, you can't see it on Instagram because you have to go onto the YouTube link to be able to find. I'm doing a fancy thing with Instagram and YouTube. So you have to click on the YouTube link, which I hope popped up on Instagram. Maybe it didn't. Oh, well, there'll be another time. There's another time. Okay, so whereabouts were we? I'm talking for a long time. I need to sort of just stop waffling on. This kid, so long story short, if we have a correction to a spinal dysfunction, this child, this case, we actually saw some pretty positive responses. Okay, I used particular outcome measures to determine if it's going to be to tell how exactly things are coming along. So we used outcome measures such as rate of weight gain, parental perception of breastfeeding, and cervical spine range of motion as well. So increased rate of weight gain, cervical spine motion, and I think I did talk about them elsewhere. Anyway, what was really lovely is that we actually saw, after the first treatment, mother reported an improvement in suck and swallow. Okay. After the second treatment, there was improvements in unsettled behavior. The parents started reporting that the attachment was a lot better. Suck quality was a lot better. But what was really quite not amusing, interesting with this case is it took until, I think, about the 6th or 7th treatment before we started getting a really big improvement in cervical spine range of motion and rate of weight gain. This baby was putting on weights between 15 and 30 grams per week. Now, at 4 weeks of age, we should be putting on 30 grams at least a day. Okay, so to be putting on that level of weight over a week, we can see where we're ticking into failure or thrive and concerns with that. Brilliant. Oh, thank you. The interruptions. Train of thought, back on track, 30 grams per day. So what was really interesting is after the 6th treatment, weight gain jumped to 70 grams per week. And it wasn't until after the 6th treatment, so at the beginning of the 7th treatment, was she actually full and normal cervical spine range of motion. Okay. 7 treatments, that's a long time. But at that 7th treatment, that mum came in and said we'd put on 140 grams in the week. That then jumped to 200 grams in the following week. This happened after all the cervical spine stuff disappeared. Could cervical spine have been influencing maybe a pain-based behavior? Could it have been disrupting vagal activity? Lots of questions inside that one. Again, I don't want to make any claims in this one because, well, this is a case study. It's level 5 evidence. So it's not really going to do us a lot of good if we sit there and try to make claims with it. But the key part, and what I really liked with this one, is the kid got better. Okay, mum noticed a very strong improvement in breastfeeding ability. Mum noticed a strong improvement in weight gain. And by the end of it, we were much, much happier. So this is one of the things that we find when it comes to most children and breastfeeding difficulties and manual therapy. In fact, there are many studies that are out there that actually do discuss about manual therapy and breastfeeding difficulty. Okay, in 2019, Dr. Joyce Miller, I hope it's Joyce Miller, she wrote a wonderful paper that looked at pre and post treatment. So it was a survey-based, oopsie daisies, something just happened then. It was a survey-based system, and they did a survey at the start, and they did a survey at a follow-up, and they found that the kids who had that treatment, sorry, I just need to click some buttons. It did a funny thing. They found kids who had undergone treatment had a substantial and a statistically significant improvement in scores after this one. Further than this, there was a scoping review done by someone else. I've just forgotten completely who it was. I think, let's have a look. Cheryl Hawke, that's the one. She did that as well. And again, it's finding that there was a moderate improvement. In fact, I could see, there's a quote here, there was a moderate level of favourable evidence supporting manual therapy for infants with musculoskeletal dysfunction and breastfeeding difficulty. So that then fits what we're talking about with this case. This case had indications of musculoskeletal dysfunction tied in with its breastfeeding difficulty. So how can we tell if a child has musculoskeletal dysfunction? Well, could there be change to normal range of motion? Could there be difficulties with feeding? Have you had your child assessed by an IBCLC and they couldn't quite find any reason here? Could it be a reason here? Okay. Now, I'm not going to make the statement that chiropractors alone can fix this. No, that's not true at all. Okay. There are many manual therapists out there who are trained and able to provide the care that is required. But I'm going to put this out to you and say, if you have a child with breastfeeding difficulty and you've had them assessed by your IBCLC and we're questioning, is it a tongue tie, is it this, is it that, would it be worthwhile having your child assessed by a manual therapist, be it a physio or a chiro or an osteo? I mean, granted, it's a little bit tricky at the moment because of this whole COVID situation, but hey, health professionals are still considered an essential service. If you have a child who is not feeding and at risk of possibly failure to thrive, would you consider that to be essential? Look, a lot of the places that I know who are still in operation are undergoing a lot of care in regards to ensuring everything is nice and clean, everything's been sterilized, everything's wiped down, we're keeping that social distancing kind of stuff, physical distancing kind of stuff going on. And we're all doing the right things to try and keep your kid in good, safe, healthy hands. Okay. Well, that's all I really wanted to talk about, just a little bit about how manual therapy can tie in with breastfeeding difficulty. I hope you've enjoyed this kind of face-to-facey kind of stuff. You know, it's a little bit different to what I usually do, but given the times at this point, we've got to try and do things a little differently. So feel free to do that whole liking, share. I don't know how to describe that thing. What do they say on YouTube? Oh, yes, YouTube, yeah. Subscribe. That'd be wonderful. But in the meantime, if you have any other questions, if you'd like to talk more about this one, I'm more than happy to. You're welcome to shoot me a message on this thing or on this thing or on anything. You know, heck, you could even write me a letter and I'll write one back to you. Otherwise, enjoy the rest of your evening. Thank you very much for your time, and I'll speak to you again soon. Thank you. Bye-bye. Clicking this button, moving this one, clicking things, and I don't know how to stop. Where do I stop it? Okay. Bye.